There's a new metal called Guardinium. Dr. Chol came here from sunny San Diego, California to ask, what are the potential reasons why we get surgical site infections? First, I have one of my heroes, Dr. Kirkwood, professor at Stanford.
Guardinium is made similar to stainless steel.
And then I have another equally smart and charming and handsome surgeon.
Making me blush. An SSI is a never event, even though it does happen sometimes.
Oh, look at this suction.
This is a T-handle here.
Whole channel going all the way through.
Yeah, exactly.
Dr. Chol came here from sunny San Diego, California. Today is a great day. You know why? I have two awesome surgeons visiting me, and we're going to talk about really important things related to spine. So first, I have one of my heroes, Dr. Kirkwood, professor at Stanford, and I've been looking up to him my entire career. And you'll see when he starts talking, he's very, very smart and authoritative. And then I have another equally smart and charming and handsome surgeon.
Making me blush.
He just got done with his training, so he's fresh off the boat, if you will. He is an attending neurosurgeon as of this week.
Correct.
In Chicago.
That's right.
And I'm kind of right in the middle. I've been in practice for about 20 years, so let's get started right away. One of the things that I cannot stand about surgery is getting an infection after surgery. I feel dirty. So anything that we can do to mitigate that problem, I think is a very worthwhile goal. So let's talk about that. So first question is, we call it SSI, surgical site infections. What is that? And why is it such a big problem?
Well, it is, as you say, Joe, a very big problem. In fact, I think by the latest count, billions of dollars are spent every year in healthcare for taking care of what you described as a surgical site infection. And a surgical site infection can simply be thought of as that after the wound is closed and the dressings are placed on, sometime after that, whether it's the next day or a week later or a year later, the wound can start to fall apart, get red, and oftentimes filled with infectious material and pus, and that is a surgical site infection. It's not remote from where the incision was, it's at the site of the surgery itself.
And it's very painful to have an infection, right?
Very painful, because as you can imagine, for anybody who has had a cut, blister, or otherwise, infections tend to build up gas and pus, and they start to expand. And if it starts to expand in a closed place, which is where the wound is, a lot of pain results.
In the famous words of my mentor during residency, Sergey Nekrish, he used to always say that an SSI is a never event, even though it does happen sometimes. Like the literature says, approximately 1% of the time. But in reality, in practice, I would say it's less common than that, less than 1%. But this guy that I worked with had a zero tolerance for SSIs. And if there ever was an SSI, it was this massive investigation to try to figure out who was responsible, number one, but also if no one was responsible, then why did it happen? So we had to identify a root cause analysis.
Yep.
Yeah.
But you are not far from the truth in terms of that never event, which has come into use in medicine in general, orthopedics specifically, and especially spine, such as, for example, operating accidentally on the wrong side.
Exactly.
Or getting an infection nowadays from a catheter is now considered a never event, which means that the hospital is not paid for anything related to that, so to speak. And there is a lot of talk now that a post-operative surgical site infection may very well soon become a never event in the eyes of the payers and the administration.
You know what's fascinating? I didn't mean to interrupt you. I was going to say that I went to Italy not too long ago. They told me that if they got an infection for one of their procedures, they would have to pay out of their own pocket for the take-back. Not necessarily all the hospital fees and stuff, but they wouldn't get paid for that surgery. So when I told them, I said, sometimes we have to do a washout or whatever, they were baffled by the fact that a surgeon still gets compensated.
Okay, you brought up a really interesting point. which is related to what causes surgical site infections. And just to play devil's advocate, because I totally agree with you, this should be a never event. But to lay the blame on the surgical team by themselves seems a little drastic when we sit down and just ask, what are the potential reasons why we get surgical site infections? What are the predisposing factors? It's not all the surgeon, is it? There's other reasons why wounds get infected. So let's talk about that. There's three things, but one of them is the patient.
Of course. Someone could be immunocompromised.
Yep. How do you address that situation in your residency? Like, what was the single best way to address that topic? Patient-related risk of infection.
Right. So risk of infection related to the patient, things like diabetes, if they're a smoker, the likelihood that they're going to heal that wound is a lot lower, right? The vascularity is not there. The ability for them to heal and close that wound is significantly lower than somebody that is healthy and is a non-smoker and somebody that's not immunocompromised. So from that aspect, number one, patient selection was a huge thing that we had to do. Number two, we always checked an A1C before.
Exactly.
Yeah, we always had to do that. We always assessed a person's smoking status, nicotine status, all that stuff, and then counseled them on smoking cessation if that was the case.
All right, so what about patients on chronic steroids or chemotherapy? Is that a potential problem for post-op infections?
Absolutely. Someone on steroids has a diminished immune capacity to take care of a foreign intervention into their body, whether it's the surgery itself or the instrumentation and metal objects that are placed in there as well.
Yep. So addressing surgical site infections starts even before the surgery.
100%.
Making sure that the patient is essentially optimized as best as they can possibly be to undergo the surgery. So hemoglobin A1C is huge for us. We don't have a lot of steroids, patients that are on steroids, nor a lot of patients on chemotherapy. So I would say by far, at least in my practice, the hemoglobin A1C is the number one thing that affects surgical decision making. So anybody over a hemoglobin of 7.0, we wait to see if we can get it lower.
And I would say that's one of the only things that is a modifiable risk factor to a certain extent. I would say that is something that the patient can adjust and fix and work on to improve their likelihood of having a successful outcome.
How big of a deal is hemoglobin A1C at Stanford?
I mean, it's as big as it is for you here at San Diego. Yes, there are many people who have a hemoglobin A1C that's higher than 7, let's say, who, again, outside of an emergency situation, are counseled to bring this under better control before undergoing an elective operation. I would also add, what we've danced around a little bit is because in a complex surgery center such as yours and ours, there is a lot of people who've had surgery before.
So the other risk factor is previous surgery, right?
Yes, 3, 4, 5 surgeries before. The tissue structure that you are entering back into is completely different from the native population that was there before. The blood supply is obscured. Scar tissue disrupts a lot of the transfer in the lymphatic system. Drainage is reduced, the normal drainage patterns that are there. And thus, that's a big problem, especially when you get to the more complex operations.
It's amazing that people don't get infections every single time, actually, when you think about it.
Yeah.
So let's go back to this one thing that you said. The infection rate overall is roughly 1%.
Correct.
It used to be 2%. And that doesn't seem that high, but if you do 200, let's use a round number, 300 surgeries a year, a 1% risk means you're gonna have 3 infections in that year. Every year. Each surgeon.
Yeah, and each of which is potentially life-threatening.
Yes.
That is dangerous.
And very, very expensive to treat. So
100%.
to have 1% is a pretty big number. I don't think we can ever get things to 0, but there are lots of procedures that have a 0.01% complication rate. I think that is not that unreasonable of a goal. It will depend on factors like the patient and the surgery, but that is a big number that we definitely need to get down. So having said that, once you get past the patient, then we're in the OR. There's a bunch of stuff that we do in the OR that addresses that infection problem. What would you say in your mind that is like 3 really important things that you do in the OR to address this problem?
Of course, sterility, number 1.
Mm-hmm.
Preoperative antibiotics would be another one that we do. And then intraoperative antimicrobial irrigation is another thing that we would do.
What do you think is really important?
Well, I would echo those. Those are 2 or 3 of the principles we were taught. All of us were in our training. One is to, obviously, sterility has to be maintained.
Meticulous sterility.
Adequate irrigation with antibiotics at the time. There are other factors, especially our joint replacement surgeons are very concerned with, and that's the amount of traffic inside the operating room.
Yep.
A lot of times people will place signs on the front door of the operating room which say, do not come in, there's an operation taking place with metallic implants, go. Because it has been shown that with the rise in the amount of foot traffic in an operating room, so goes the frequency of infections.
And this is more of an ortho thing, I think, but you guys wear those suits, those space suits sometimes for joint replacements.
No, not yet. I think joint replacements are the only one who do that, so to speak.
Yeah. They're talking about the big hoods.
Yeah.
Yeah.
With the fan inside.
Yeah.
Yeah. But then there are also other things that can be and are done in many locations, and that's not only the irrigating with the antibiotic solutions, but at the end of the case, placing antibiotics in the wound.
Yes. All right.
itself.
So if you were to ask me that question, what was dramatic? So as you know, I'm a minimally invasive surgeon, so I'm always comparing what's the difference between open and minimally invasive. And for the longest time, I would say one of the big benefits of minimally invasive surgery is a much lower infection rate. And then vancomycin powder came out, and we would sprinkle the antibiotics into the wound. And then all of a sudden, I couldn't make that argument. It was a dramatic change in the infection rate in open surgery. I mean, dramatic.
So you noticed the difference?
Huge. Not in my patients, but when
In
I was
general.
at the university, we never did washouts. But we had a big open surgeon, and once a month or once every other month, there'd be a washout. And then all of a sudden, like, when was the last time you did a washout in an open case?
Yeah.
6 months ago. It's not 0, but I'm surprised that you can take an external stuff, sprinkle it into the wound, and have a dramatic effect. Have you noticed the big difference, and do you do that?
Well, you bring up a salient point. I was just in the Western Orthopedic Association meeting last month, and we presented our data going back 15 years, so to speak, where at about the 7-year point, we introduced a 3-pronged approach to preventing infections. And as we've been talking about, there are things you can do before, during, and after an operation that will help with that. The before was we would use not just the iodine preparation of the wound, but a chlorhexidine scrub beforehand.
Oh, we forgot about that, yeah.
And then during at the end of the operation, and now again, what we might delve on just briefly is that there's a difference between whether an operation is in the front of us or there's an operation in the back of us. Because operations in the front of us have such a better blood supply. We don't lie on our front when we're in the recovery room, and all the drainage goes away. So I dare say in my 35 or 40 years, I can't think of an anterior incision that ever got infected. So for posterior operations, what we do is we put, as you said, vancomycin into the wound. And it's not just the instrumented operations with big long rods and stainless steel and whatnot. It's even the small discectomy operations. We use vancomycin. And then the final thing was something you can do after the operation. When you and I were residents, training, maybe not yourself, you're too young, but the golden rule was that every house officer changed the dressing every 2 days to see how things looked. But we learned that may not be necessary. And so now we put a dressing and an IO band, a gauze over that isn't changed until they leave the hospital, or in smaller operations, 5 or 6 days later. So those 3 things took a overall infection rate of around 4% including, big scoliosis operations, down to about 0.4%.
I'm going to play devil's advocate for 1 second, because there is literature that says that the vancomycin thing is ineffective. It doesn't do anything. I think there was a paper published in 2018 that was a case series that looked at, it was like a randomized control, looked at patients that got vanc, patients that didn't, and assessed that there was no meaningful difference between the two, but every surgeon, including me, that I know still does it. So I still put vanc in because you still believe in it.
It depends upon how diligent you are the rest of the hours that you are in there. Understandably, if you're sloppy with technique or other of these things we've been talking about, it may not change. But if you follow basic principles of surgical infection protocol, a little change like that can make a big difference. You do bring up and adolescent idiopathic scoliosis doctors all over the world routinely put vancomycin in there. Now, you bring up a salient point that there is a downside potential to using vancomycin, in that if a lot of antibiotics are thrown in there that certainly kill staph and strep, which are the most common organisms that we see in post-operative infections, it does have the potential, and some people have experienced that, to run the risk of the production of other bacteria, gram-negative bacteria and such like that, that may not be resistant, that are more resistant to vancomycin than you would have seen otherwise.
Dr. Z, you said something really interesting. We see lots of studies, clinical studies, randomized controlled trials, comparative studies, which show one thing or another. And you mentioned something about a study that you saw where vancomycin powder didn't really have that big of an effect. But when you say that, I think to myself, I don't believe that study, because at least in my anecdotal experience over 20 years, once we started using vanco powder, the infection rate in the hospital went way down. And you noticed the same thing, and you actually studied it because you're a smart academic person and a leader of the field. So you actually counted everything. How big of an effect was vancomycin powder in your study?
Well, in easy to understand terms, I would suggest that it, on average, from a posterior surgical approach, it drops the rate of infection by tenfold.
Wow.
I have goosebumps when you say that, because I would have never thought that would be the case, but it clearly illustrates there are opportunities to make some big impacts on this field, and we just need to step back and start thinking of other ways instead of just relying on the same old thing all the time.
You bring up a good point, because there are things that you and I and we can do in terms of our surgical technique and our patient preparation and whatnot, but that's only part of the story. The other part of the story is the operating room itself. As I said before, the number of people walking in and out of the door has something to do with it. How the sterile equipment is positioned inside the room and protected, so to speak, from contamination. And then, as we will see, you get down to the instrumentation, the metal, the tools, and all those other things themselves. Are they necessarily clean enough to prevent an infection post-operatively?
Because we use a lot of tools and instruments in the OR over and over again. So they get cleaned, they get sterilized, and they get back on the field, and we reuse it again. So one of the ways we can get infections is to introduce bacteria from an instrument or a piece of equipment.
It sounds crazy, but yes, every time an instrument gets nicked or scratched, which it will do in its everyday use, that sets up a little nidus that bacteria love to harbor.
It's a new crevice for bacteria to form, especially for things like suction tips. Like for open cases, I think patients would be surprised to learn that I'd say 90% of the time we got a suction in one hand and then an instrument in the other hand. So that suction tool is being reintroduced into the wound over and over and over, and each time it comes out, goes back in. It's another risk for infection.
There's only one instrument that even remotely comes close to the suction and spine surgery being in the wound, and that would probably be like a kerosene rongeur or something. I mean,
I would say so.
And in me, I always have a sucker in the wound. So the suction device is one of the most important pieces of instruments that we use, and it's the instrument that gets reused all the time. It's got a hollow channel, and sometimes blood gets in there. And every once in a while, I'll get the instrument passed to me and it won't look that clean. So if there's one instrument that I would want to know that is really clean, it would be like a suction device. Like, what do you think? What is the thing that you are most focused on?
Well, again, it depends upon your type of surgery. I myself don't do very much of the minimally invasive surgery at all, being a little longer in the tooth than you are. But, we use the Cobb elevators for exposure purposes, from top to bottom, in and out, in and out. Oftentimes, suckers or more than one sucker at a time. Mm-hmm. And as you said, yes, the suction and things like the Cobb, but also the retractors, who are these little instruments that go in the top and the bottoms of wounds that spread blades out that hold the wound open while we're doing our operation. But that entire time, they're pressing against tissue. They're cutting off the blood supply to that little piece of tissue, which then becomes a secondary location potential for bacteria to go to when there's no blood supply.
And thinking about it, I'm just amazed at how much metal we use inside the wound. So
For sure.
That's why we've brought us together, because if we're going to use a lot of metal in the wound, wouldn't it be cool if we had a metal that can also help in the cause? So let's talk about that, because there's a new metal called Guardinium, which is a very cool name. And the metal itself has antimicrobial properties. And you seem to know the most about this, as usual.
No.
So tell us a little bit about Guardinium. What is it and how does it work?
Well, Guardinium is a metal, not unlike a lot of the metals that we've used historically, going all the way back decades to when the first metals, and we're talking about the metals that go into to fasten to the spine, to hold it still so a fusion can take place, or in scoliosis.
Screws and rods, right?
Screws and rods to bend the spine in a certain position and hold it straight. Those things are made for staying inside the spine basically forever. Stainless steel was the first to be introduced on a consistent basis around 1960. And since then, in the spine, we have graduated to switching to titanium and cobalt and chromium and things like that, which are a little bit lighter. But the problem with stainless steel is that in a lot of situations, in a warm, heated, compromised situation like a wound, bacteria love it. And the repellent capacities of stainless steel is not that strong. In fact, bacteria can form a little shell around themselves when attached to stainless steel that prevent any antibiotics from ultimately getting in there and trying to get rid of them. Titanium.
Degraded biofilm. That's what
Exactly.
you're talking about.
And
how does Guardinium differ from stainless steel in that way?
So Guardinium has two very dramatically positive properties. One, that it's a little bit different than stainless steel. In fact, that it is actually stronger. It takes a certain amount of force to bend a stainless steel rod. It takes more force to bend a Guardinium rod. So that has the potential for maintaining corrections and not breaking as much as a stainless steel rod might do from fatigue. The second component of it is that the Guardinium is made similar to stainless steel, but it has an element of a special copper alloy in it. And the way this will work for us is that once it is introduced into the wound, if a bacterium happens to land on that Guardinium, there's what we call an ion-to-ion transfer between the copper that's in the metal and the cell membrane of that bacterium. So when the cell membrane lands on the copper, there's an ion-to-ion transfer between the copper and the electrons of that cell membrane. It's now depolarized, holes break into the cell membrane, and that thus, without the protective barrier around it, that bacterium dies.
Okay, I told you he was smart. I think what you're saying is that Guardinium has like a copper ion, like a charged molecule. It interacts with the cell wall of the bacterial membrane, and that electrical interaction basically like disintegrates the membrane and kills the cell by rupturing the membrane.
Correct. And
that's
in theory, it should
cool.
last as long as the metal's in there, that copper remains in there, and any bacterium that might later on come into contact suffers the same fate.
So it's not like a drug. It is a metal killing surface that whenever bacteria lands on it, it will die.
Exactly.
So is it safe to call it self-sterilizing?
Yes, you can, because I mean, we sterilize the instruments that are placed inside the womb, but we also sterilize the instruments that are used, like you mentioned, the suckers, the Cobb elevators, the retractors. Those, again, like I said before, are potential sites of infection if not properly cleaned, stored, and cared for. But if you have a material such as Guardinium that is still cleaned, sterilized, and cared for, but has this additional purpose in it of protecting against bacterial invasion, well, that adds another level of security to your procedure in the first place.
So the idea is you've got this metal, say it's an instrument like a sucker, it's been washed and sterilized for reuse, and it's just sitting there, and the world is filled with bacteria. Mm-hmm. Some bacteria land on it. If it's stainless steel, it lands on it and starts a little party. If it's Guardinium, it lands and gets killed.
That's the easy and straightforward way to look at it.
So the company says that it takes about 2 hours to have a 99% eradication of the existing bacteria that is within that field. So things like methicillin-resistant Staph aureus, E. coli, that kind of stuff gets completely eradicated, 99 point something. Based on those data, is it safe to say that something like this could be incorporated into the OR so that we could reduce the risk of SSIs?
As I've been wont to say, the question we should basically be asking ourselves is, why don't we? Mm-hmm. Because it has all the fundamental properties of everything we do up to date in the surgical pavilion, with the additional security that there is almost an astronomically low rate of surgical infection.
Mm-hmm. And you brought up something really interesting. We can use the metal for implants, like screws and rods that we put into the patient and it stays in the patient. Or we can use it for the tools that we reuse over and over again. I can imagine that creating a new implant that we put in a patient with a new metal is going to be really difficult to vet out, get through the FDA, and actually be ready for use. But in my mind, I'm just as concerned with all the instruments that we use, especially the ones that we reuse. And because we're not leaving in the patient, I suspect that it's going to be a much easier effort to make this happen. So I'm thinking I as the first project, the sucker, because that's the instrument that I really use a lot. It comes back and forth into the field, and it seems like something simple to fix. Plus, let's face it, the suctions, the ergonomic design has not changed in 22 years or longer. Mm-hmm. I would like one that just fits so nicely into my hand, sort of like my golf clubs. I mean, over the last 20 years, my golf clubs have evolved.
Yeah.
Suction has not changed one bit. So I'm always looking for, killing two birds with one stone. Let's introduce a technology that will address a significant problem. And then let's, at the same time, make things easier to use. So with that in mind, what would you work on first? What instrument do you like the best? What do you think is the most important to have made out of Guardinium other than implants?
We talked about it briefly. I would say the Kerrisons are the next most commonly used. No, actually, I take that back. Dr. Wood said retractors.
Yeah.
I think retractors are the next best thing. I would say those are in there longer than the suction. I would say that's probably the most critical. I would focus on that for sure.
What's your vote?
I would echo your sentiments. I mean, all of us have seen, especially after a long open case, especially, when you take the retractors, release them, so to speak, and let the wound edges come together. I mean, there's clear damage to the tissue, the muscle, the soft tissue, the skin itself. And again, any damaged tissue is a ripe site for infection.
100%.
So if you can ward some of that potential off by having an antimicrobial implant, then again, your risk of problems thereby will go, especially in compromised individuals, as you see. If you're operating on somebody obese, smoking with diabetes, but it's an emergency operation that you have to do anyway, then you can help yourself a great deal by using anything you can to reduce the risk of a post-operative surgical site infection.
I love that. So these are the actual Guardinium metal instruments that exist today. Some of them, right?
There are 3 of them.
3 of them. Okay.
Some of the most commonly.
So this is a handle. It feels like normal metal. Oh, look at this suction. It fits so good into my hand.
This is a T-handle here. So we got this retraction device that acts, I guess, on a universal quick connect mechanism. So that's pretty cool, actually. Which is really nice because obviously handles are going to be one thing that we're going to make a lot of contact with, especially stuff like this that is interchangeable, right? So I would say this is a great idea here. But yeah, it feels like you said, regular titanium.
Something like this passes back and forth from the scrub technician to the surgeon multiple times, and each time there's a handoff, there's a chance.
Yeah.
Small, maybe it is.
And then look at this. This is how the stem goes in and out. That little thing can be a place where you trap debris, and then bacteria contaminates it and grows in there.
Correct.
And then the suction, I mean, there's a whole channel going all the way through.
Yeah, exactly.
So I'm most excited about the suction, but I can see how all these things, if we can make everything like this out of Guardinium, it may make a big difference. And it's easy to do.
I mean, I just want to emphasize, so the company is making these pretty big claims. And I guess one thing that I really want to know is how did they figure this out? I mean, are they sitting there taking swabs every time interval, trying to check to see how much bacterial growth? How do they know how much bacteria is actually on this?
Well, what they did was they had infectious material that they placed onto the metal, and then they would take that metal and introduce it into a petri dish of growing material, so to speak, and using optical microscopy, study at time intervals how many colony-forming units of bacteria were still there. And then they would go back a little while later and look at the same thing, and you could trace on a graph form the number of units that essentially extinguished itself essentially completely. And the way that machine would work was that it could tell the difference between a live bacteria and a dead one, because the dead one, based on what we talked about at the very beginning, has its cell membrane ruptured, and to this microscope looks different. And so they can count, in ways that you and I can't, the number of still alive cells that are there until there are no still alive cells in about a couple hours.
That's amazing.
And these are kind of like standard tests that we run on all things that we are looking for in terms of bacterial counts and antimicrobial activities and things like that, right? These are these assays that we rely on for many different other tests to assess infection risk.
There are standard methods for any microbiologist or someone working in that field to ask questions like this, whether it's spine surgery or geology or anything. There are methods to do, and this is one of the standardized techniques involved.
Like anything new, we always have to vet it out and test it in multiple different scenarios. So in the end, we have to show that it actually decreased the clinical infection rate after surgery, not just in a petri dish. So I think there's a lot of work that needs to be done still, but we now have something totally different that we've not looked at as a way to attack this problem. And I'm a big believer in like multimodal therapy. So you're attacking a problem in multiple different fronts, and now we have a third front. So I'm personally really excited about something new like this.
And I would echo that 100%. So the thing that I would want to see is maybe a third-party study, kind of like we discussed earlier, is to see how this would actually work in the hands of a non-biased party. So if that is really the case, if this can really eradicate 99% of bacteria, this is going to revolutionize the field of surgery, in my opinion. You can make everything out of Guardinium. You can make mail stands out of Guardinium at this point. If you poke a hole in something, you're going to be less likely to contaminate something.
The potential is immense. I agree with you.
And as you said, Joel, I mean, you can work on two different fronts at the same time. In other words, my theme for my use of this is why wouldn't you? I mean, there's certainly no reason not to use it because there's no downside, but there's a potential huge upside of reducing your surgical infection rate. But as you suggest, to put it into numbers that people can read about and picture themselves is going to take a little more time because, as you said, with an infection rate now down where they are, it will take many, many operations using this and not using this to show that this is statistically better than not using it.
I am really excited. It's an exciting time in spine, and there it is, Guardinium. And it's an opportunity to also make things look, feel, and handle in a lot better way ergonomically too, because we have to think about ourselves every once in a while. And you should see this callus I have on my finger from my suction use.
Honestly,
and I think I broke a nail on my last case from it. So we can attack infection in multiple fronts. We can improve the ergonomics of the operating room so that you don't get injured.
Truthfully, I mean, this has a premium feel to it. I like it. It's got a good weight to it. It feels smooth. I like the matte finish. Honestly, I think it looks pretty cool. I don't know if you know this question or this answer off the top of your head, but I know you mentioned the forces required to bend this type of metal compared to stainless steel. Do we have any data based on titanium? Or you can just use stainless steel as a reference.
Compared with titanium?
Yeah.
Oh, well, it's much stiffer than titanium.
Sure.
And there, I don't have the graph with me, but you can see where the company tested multiple different types of materials, 10 or 12 different ones, from titanium to cobalt to stainless steel to Guardinium and whatnot, and you can see the graph of the Newton forces necessary to exert a certain amount of bending, and you can see that Guardinium is about 3 from the toughest, so to speak, and stainless steel is way down here in the middle.
Now, is the idea to make implantable rods for fusion cases with something like this?
Right. Ultimately, I imagine that the plan would be that
everything,
to a certain degree, everything in the operating,
for sure.
Whether it's the instruments that hold things out of the way, to the screws that we put in there, or the hooks we use, all that will one day potentially be replaced from being titanium or stainless steel or whatnot to something like Guardinium.
And we're just talking about spine. Imagine hips, knees, catheters. I can't imagine how many different little implants that other specialties put in with some metal in that.
Cranial implants, that would be a huge thing.
Yep.
Exactly.
Definitely.
And there it is, yet another new technology that we want to incorporate, and it could be huge. So I hope we can do this again because I really like how we have all the generations covered and a wide breadth of experiences so that as this moves forward, we can talk about it some more because I'm sure there's lots of interesting things that are going to pop up as this progresses. So thank you, Dr. Wood. Thank you, Dr. Z. And I hope I see you here again very soon.
Thank you, Joel,
Likewise.
for having us.
It was a privilege. Thank you.
Thank you.